I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness.
Today, as most of you know, April is Parkinson's Disease Awareness Month. So today it is my honor and privilege to interview Dr. Laxman Bahroo, who is a specialist in treating Parkinson's disease. Dr. Bahroo, welcome to the show.
Thank you for having me.
My first question is, what are some of the hallmark features of Parkinson's disease, and what are some of the most challenging symptoms to treat still today?
So Parkinson's disease is a progressive neurodegenerative disease. It is still a clinical diagnosis, and its main hallmark features that bring someone to the attention of a neurologist are the motor features. Motor features such as tremor, typically at rest, rigidity, specifically cogwheel rigidity, and slowness of movement. Parkinson's often begins on one side of the body, typically involving an arm or a leg, and then gradually progresses to involve the whole body. Parkinson's, however, is beyond just motor symptoms. It involves an array of premotor symptoms such as constipation, which can occur for several years before the onset of the diagnosis of Parkinson's, REM behavioral disorder, which is the acting out of dreams and vivid dreams, which can occur for several years before the disorder. It can also involve issues along the lines of decreased sense of smell or anosmia. And many of these symptoms go undiagnosed and untreated or unrecognized until the diagnosis of Parkinson's disease. Because Parkinson's is a progressive neurological disease, we have a lot of challenges in treating Parkinson's. If you were to list off a couple of the challenges, they would go from being able to manage the long-term course of Parkinson's to being able to manage some of the non-motor progression that happens. And if one were to look at a list of the top 5 or 6 things that are bothersome to Parkinson's patients, many of them are motor fluctuations, which can occur with advancing disease with having more off time or dyskinesias, balance difficulty, swallowing difficulty, issues with mood and apathy, issues with dementia, issues with psychosis and hallucinations, and issues with managing tremor. So Parkinson's has a lot of challenges for many of its patients because many of us see Parkinson's patients, if they were diagnosed today, they would probably be alive for about another 2, possibly 2.5 decades. So as I tell patients with Parkinson's, we're treating somebody and a disease state that is a marathon, not a sprint.
That's such great information. Thank you for sharing that with us. What would you say has changed in the last 20 years in terms of the approach to treating Parkinson's disease?
If one were to look at the approach in treating Parkinson's disease, over the last 20 years, what has dramatically changed is the availability of newer medications and different classes of medications. 20 years ago, many times patients were not treated early into the course of their disease because, quote unquote, they were not bad enough or they didn't need treatment because once you started using medications, you didn't have many other options. But over the last 20 years, we've had a plethora of options available, and many of the medications that have come out have been longer acting formulations to new products, which have helped us in the setting of using multiple medications for multiple settings to manage their medication. So we're treating Parkinson's disease more aggressively to make sure patients aren't getting more disabled with Parkinson's, but we're also managing them with a cocktail of medications over a longer duration of time.
With that, what would you say are some of the most current evidence-based pharmacological treatments available today?
So if I look at classes of medications, there are about 4 classes of medications available for Parkinson's. If you look at it from the point of view of there's the levodopa class, the next class is a COMT inhibitor class, then there's dopamine agonists, and then there's MAO-B inhibitors. And those are the 4 big classes. Now we have multiple medications in each class. The levodopa medication class, of course, has some of the newer entrants available out there. There are longer acting formulations. Levodopa still is the gold standard medication therapy. It's the most potent medication available. Unfortunately, as potent and powerful as it is, its original formulation, the immediate release formulation, just isn't long acting enough. It doesn't last as long in advancing disease, which has allowed us to have medication options that are longer acting options out there. Other ways to extend the duration is to use some of the other medications we talked about, a COMT inhibitor class, which allows the medications to get more of the medication into the brain. There's another COMT inhibitor called tolcapone, which of course works both centrally and peripherally, and entacapone, which works mostly peripherally. On the other hand, in the MAO-B inhibitor class, we have three medications. We have selegiline, we have rasagiline, and we have safinamide. And all of them are designed to basically reduce the breakdown of dopamine after it's been made from levodopa or the person's endogenous dopamine. And that allows the dopamine to be recycled and stay in the synapse longer, increasing the duration of time and effect. The next line of medications is the dopamine agonist class. Now, the dopamine agonist class are basically chemicals that are designed to look like dopamine. And they're basically, we have three medications in that class currently. We have pramipexole, ropinirole, and rotigotine. Rotigotine is a patch formulation medication, and pramipexole and ropinirole have extended release once a day formulations as well, which have been helpful in many patients, so they're reducing the pill burden. That class of medications is something that I would call a moderate potency class that's designed to help reduce the symptoms of Parkinson's, but is usually used in adjunct or combination with other medications in advancing Parkinson's.
What are some adjunct treatments in addition to these that are available that might be able to help?
There's two different ways of looking at adjunctive treatments. If I were to look at adjunctive treatments outside of pharmacological treatments, and please keep in mind, the medications we mentioned are the medications used for motor symptoms of Parkinson's. There's a variety of medications available for non-motor symptoms, and I'll talk about them in a few minutes. But if you looked at adjunctive therapies, almost every Parkinson's patient will be in some form of an exercise program or physical therapy and rehab. So rehab is really an adjunctive therapy in Parkinson's patients, whether it's speech therapy, occupational therapy, or physical therapy. Many of my patients are regularly encouraged to exercise, and exercise becomes an integral part of their lifestyle, along with managing a reasonable diet to allow basically their bowels to have a regular amount of fiber intake, so to prevent constipation. On the other hand, segueing into non-motor symptoms, there are a variety of non-motor medications available as well. We don't have medications for everything, but many of our patients will end up on antidepressants because depression has is much more prevalent in Parkinson's patients. Patients may end up with dementia, so there's anti-dementia medications that'll be utilized. Patients may end up with orthostasis, so they'll end up on medications that can elevate blood pressure, such as midodrine, fludrocortisone, or droxidopa. And there's patients may end up with hallucinations, for which there's medications to reduce the hallucinations. Unfortunately, most anti-hallucination medications and neuroleptic class of medications interact with the Parkinson's medications because they block dopamine. But there is pimavanserin, which actually does not block dopamine and is indicated for Parkinson's disease psychosis.
What is known about the effects of botulinum toxin as a treatment for Parkinson's?
Botulinum toxins is an interesting class of medications. It's had an interesting history over the last nearly 30 or so years of being available. There are multiple classes of botulinum toxins available in the United States. There are actually 4 botulinum toxins, 3 type A's and 1 type B. And it's interesting because its uses in Parkinson's, it has a lot of potential for use in Parkinson's because Parkinson's patients will have a lot of affliction from dystonia, as well as they'll have an affliction with sialorrhea as well, which is excessive drooling. And botulinum toxins have been approved for usage in sialorrhea, and they've been approved for usage in dystonia. And we find them useful in individuals with either foot dystonias, which are basically abnormal spasm and posture of the leg or the foot, or issues with regards to abnormal posture of the neck, or excessive drooling. And even in some patients with Parkinson's who may have blepharospasm or jaw dystonias, where botulinum toxins are responsible for relaxing these excessive and overactive muscles and improving or restoring to more normal function.
What are some of the challenges to treatment that still exist today?
I would probably say the biggest challenge to treatment is the fact that we have very little to nothing that actually modifies the course of disease. It's as a progressive disease, we have almost nothing that can alter the course of disease. Now, there may be therapies that may target alpha-synuclein on the horizon. They're certainly being tested. And there are antibody tests as well as oncological medications that are being tested out there that may show some benefit with mobilizing Lewy bodies, which is the hallmark of pathology in Parkinson's disease, and mobilizing and targeting alpha-synuclein, which is what Lewy bodies are made up of. And that may be one of the challenges that we have to face, is ultimately how do we alter the course or progression of this disease. But then other challenges are, of course, how do we manage things on a day-to-day basis in clinic where we don't have non-motor medications for a variety of things, such as specific medications for REM behavioral disorder, or we don't have medications for individuals with apathy, and even for some of the medications that have come out, we only have one medication available in that class and not multiple medications. And of course, one of the challenges I would say is that since so many new medications come out, one of the big challenges that affects providers on our end is the ability to understand and cogently be able to create a regimen from all these medication options that we have, that we almost suffer from a little bit of fatigue of having too many medication options and not being able to do anything with them because we're reluctant to try them.
What are some of the treatment strategies that are on the horizon? Can you tell us anything about those?
Absolutely. If you look back in the last 3-4 years, since 2015, we've had numerous compounds come out for Parkinson's. Some of them have been longer acting formulations that have come out that have been helpful. Some of them have been new chemicals or different formulations. And if I look forward from 2019, maybe over the next 4 or 5 years, we'll have options to treat off episodes with rescue medications. We currently just had one approved at the beginning of this year in 2019. We'll probably have one more medication that can be easily utilized by patients to terminate rescue themselves from off episodes. There's also other things in Parkinson's that we're coming out with that will put us closer to what's called CDS. CDS is a concept in Parkinson's called continuous dopaminergic stimulation. And in CDS is our ability to give medications in much more continuous quantity over a longer period of time to avoid the pulsatility of medications. And I can think of medications that are going to come out in a pump formulation, even longer acting formulations of levodopa, or medications that are going to come out in pill form that'll actually give us a much more sustained, longer acting duration of medication, as well as medications that are going to be adjunctive medications that'll also come out in long acting terms. So we're really focusing on the pharmacology of medications, trying to extend the duration of response by trying to give longer acting medications, whether we bypass the gut, which I think will become the mainstay of management of Parkinson's, because we have so much gut involvement with constipation, gastroparesis, that adds to our challenges in treating Parkinson's, that bypassing the gut will be the next thing on the horizon over the next 3 or 4 years. We'll get infusions to be able to give patients more continuous control of their Parkinson's symptoms.
How will the trajectory of treatment change in the next 10 to 15 years? Do you see a completely different approach or kind of a shift?
I do, and maybe I'm more optimistic, but if I look at the last 10 years of how we've treated Parkinson's, I treat Parkinson's today differently than what I did 10 years ago. And I use medications today that were not available 10 years ago. So I can only imagine what the next 10, 15 years might bring. I think we might end up using some of these more continuous dopaminergic stimulation options that come out maybe a little bit earlier, maybe not waiting till the patients get to have that bad fluctuations before offering it. We might move that option earlier and be able to use that to maintain function over a longer period of time. That may be one possibility. Although I may be optimistic, but I genuinely think we may have medications that may alter the course of the disease as well. I don't know if we'll have a cure, and I think many people out there believe that we might have a cure. My feeling is we probably will find something that can alter the progression of the disease, and there are medications out there that are targeting alpha-synuclein. And the optimist in me refuses to believe that all of those medications would not pan out, that something will pan out that will actually show benefit and maybe an option available for patients.
Wow, that sounds promising. How effective would you say deep brain stimulation is for the treatment of Parkinson's?
So deep brain stimulation is one of our 2 surgical therapies for Parkinson's, and it's the one that's been around the longest in terms of managing Parkinson's symptoms. Now, if you look at DBS, is very effective in the right patient, and that comes out to criteria. DBS is something that we are very strict about and very stringent about. But if you look at the entire population with Parkinson's, approximately about 20 to 25% may be good DBS candidates, because DBS is indicated for people who have a medication refractory tremor. So if they have a really bad tremor that's really bothersome to them, DBS may be fantastic at being able to reduce and ablate that tremor through surgical implantation of an electrode and programming. Another alternative indication for DBS is for motor fluctuations. Individuals that are having a lot of dyskinesias and abnormal movements followed by off periods where the medications, despite being able to adjust the medications, we're just not able to manage those. And they're having motor complications that are refractory to medications. And DBS can help because it reduces the overactivity of the indirect pathway in our brain. And by reducing that, it can actually help reduce the motor fluctuations and actually reduces the amount of medications that we end up giving to patients as well. So DBS is great in the right candidate. Now, if the patient has a lot of cognitive impairment, a lot of balance difficulties, they don't have a good response to medication, these are not patients that would be good candidates for DBS, and we should avoid that or explain to them why they're not good candidates for DBS.
I think you mostly just addressed this in the question that you just answered, but just in general, how do you know if a patient is a good candidate for a specific treatment of what is available to treat Parkinson's?
Many times, clinical trials guide us in how we should select candidates for a specific medication. Clinical trials really position the type of patients they believe might be good for a pharmacological intervention. It's important to understand the pros and cons of each treatment, the limitations that each one poses. And it's important for us to follow that closely when the medications first come out. So, if a medication is indicated for a certain usage in Parkinson's when it comes out, not only is it helpful for me to use it in that population of patients, but I have the best robust data for those patients, as well as reasonable side effects and benefits as well. So, that's usually helps me guide how I would utilize a treatment. And specific, something like DBS is a therapeutic option. I would adhere very closely to those criteria because of the fact that it involves a surgical process and which can be a life-altering process for the good in the right population and for not so good if you don't pick the right population.
So, with that, what would you say are some strategies that you recommend using to communicate with patients about treatment expectations and goals?
There's a lot of information that has to be communicated with patients with Parkinson's. As I mentioned earlier, Parkinson's is a progressive disorder. It has its set of motor features which pose unmet needs and challenges for us as well as our patients. But there's also a variety of non-motor changes that occur in patients over the course of the 5, 10, 15, 20 years of Parkinson's. And what I typically will do is if you look at each visit, I treat each visit as a way of ability to move forward. And, in each visit, we talk about a certain set of educational goals. Now, those goals may change from early on. The goals are more talking about how to manage, work and family and how to disclose the diagnosis if you feel the need to, because that's the younger population. That's the population in the late 50s and early 60s. Over the course of time, goals change to being able to manage medication times, talking about compliance, encouraging physical therapy, exercise, balancing out the various needs and goals of Parkinson's with your life. And over the course of advancing disease, we talk about whether we need to institute additional therapies for advancing Parkinson's, both motor and non-motor. We also talk about when and if surgical options may be an option, what the expectations of surgical options are. So there's a lot of educational needs that occur. My personal go-to points for educating Parkinson's patients are using the National Parkinson's Foundation. I work at a National Parkinson's Foundation Center of Excellence. So using booklets from there, we sometimes have our own guides that we put together for patients that educate them about certain things, such as, dementia with Parkinson's or hallucinations and psychosis in the setting of Parkinson's, or, orthostatic hypotension in the setting of Parkinson's. So it's important to set aside some goals. And in many ways, it's important to have visits that focus on a specific thing and specific screening of this population so that we can get more information and be able to provide education. So sometimes we'll utilize a visit where we can do a memory screening as well as a depression screening in one visit, and use that visit to really talk about the population and talk with the population that suffers from this and talk about what the next management steps would be.
That is excellent. And I love the emphasis on awareness and education, particularly patient education. So that concludes today's episode. I want to thank you so much, Dr. Bahroo, for joining us.
Thank you very much.
And thank you for tuning in to this episode of the NEI Podcast.
This podcast was brought to you by the 15th Annual NEI Congress, a psychopharmacology conference that allows clinicians to improve their patient outcomes and earn CME credits. Early bird rates end June 28th. Reserve your spot before it sells out. For additional information, see the link in the podcast description.